All this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So, this discussion today is about a preprint study that is from South Africa. Kudos to the researchers who have been spending, I'm sure, days and night to put the study together, reviewing the data, looking at it, and making sure that the whole article is put together, the study. It is a very interesting study. According to that study, media has taken a lot of liberty with how the things are. So what I'm going to do is I'm going to go, for example, media is saying that, hey, the study is showing that the reinfection risk is 3 times likely, and some of the media, this is what study is saying, and we'll look into it, that what does this mean actually. At the same time, some media outlets are also saying that the previously infected have no advantage of previous infection. So I think that that is a lot of incorrect messaging out there. So I'm going to go over the study to show what data says from author's point of view, and then provide you some commentary to identify some areas where it actually becomes very interesting that this is not as bad as it has been made to look on the media. So let's start our discussion. So this is drbeen.com. These are references. This is the reference to the study. This is a discussion which I had with James Doiga, if I'm pronouncing his name correctly, I'm sure not correctly, real life epidemiologist who also likes armchair senior statistician, honorary associate professor. So this is the South Africa. We'll look into that as well. This is a study of a vaccine efficacy from the US. Then this is a statement from WHO, which I would like us to keep in our mind as a context. The WHO said today, the World Health Organization's chief scientist told the Reuters next conference on Friday, Reuters next conference on Friday, the Omicron variant could become dominant because it is highly transmissible, but that a different vaccine may not be needed. So keep in mind that a different vaccine may not be needed. And then there are a bunch of media outlets which are, I think they just are not aware for how to process, digest, and present this data. So now let's look at the data itself. Then why not we look at my illustrations and then we look at the data. So gifts for humanity, we are sitting in our humanities coffee shop. Guess who are the folks here who are balancing this whole thing? Okay, so here is the study. It is a preprint yet. It is not yet peer reviewed either. It is a retrospective analysis. That means they looked at the epidemiological data for South Africa, and that data from March of 2020 to November of 2021. What they said was, for reinfection risk, a risk of reinfection, that means the person who is infected and then they become reinfected. Substantial immune evasion by Omicron. This is their words. Substantial immune evasion by Omicron. I want to add one tiny statement here, which is also from the study, which would kind of keep adding context to this whole thing. That statement is here on my second page. They say, this is in the study, I'll show you in a second. Vaccination status of the reinfected was not known. This is on their page 24. So if I go to page 24, this is a very important thing. Nobody brought it up. I think people are just looking at it and talking about it. Let's see page 24. This is page 24. The vaccination status of individuals with suspected reinfections identified in this study was unknown. And then they say we would recommend a more nuanced incorporation of vaccination for application of our approach to other locations with higher vaccine coverage. So there is an assumption that whoever was reinfected was unvaccinated because they did not know the vaccine status. So please keep this in mind. So what they said was that in the previously infected with Omicron, the likelihood of reinfection is substantially high. Then they said beta or delta, the previous variants, did not increase the risk of reinfection compared to ancestral variant. That means the original Wuhan variant. When you look at that variant and that variant's infection, and then you have beta variant, South Africa's variant, and then you look at the reinfection done by South African variant, for those people who were infected with the ancestral variant, there was some reinfection chances. Then Delta had some reinfection chances as well. And they're saying that Beta or Delta did not increase the reinfection chances. However, Omicron has increased the likelihood of the reinfection. So keep this in mind as well. This is the statement that is being taken, and people are running around with it. Now, what are they meaning by this reinfection? Here, they're not talking about vaccines. They're not talking about breakthrough. And they also do not know the vaccine's status. So there may be breakthrough, which they're assuming are not. So here is the infection by the ancestral variant, Wuhan variant. Then please keep this in mind as well. The protection. So somebody who got infected, now there is protection by the immune system that has become trained, just as efficacy of a vaccine. Somebody who gets vaccinated, I am vaccinated, there is an efficacy expectation. In the same numbers when we talk, and this is from the study, they said 80% protection. If I had the original infection and now I am protected from reinfection, about 80%. Good. We have seen the vaccine's efficacies to be 94%, 90%, 84%, and so on. So here, 80%. Their conclusion is also very important to keep in mind. This is on page number 3, box 1. They say the conclusion is there is immune escape from prior infections. This is another important statement. So let's go check that out. Page 3. This is the page 3, box number 1. So here they say in contrast, we find clear population level evidence to suggest substantial immune evasion by the Omicron variant. Then they say over here, substantial ability to evade immunity from prior infection. Good. So please keep these things in mind. We are looking at this data. So now what they did was, what is the definition of reinfection? What they're saying is the study contains people from 4th March 2020 to November 27th, 2021. The vaccine status is not known for the people who are declared to be reinfected or suspected to be reinfected, although they use the word suspected, but the data that has been generated is running around in the world with reinfection for the previously infected. 2.79 million people who were SARS-CoV-2 positive. 35,670 were suspected reinfected in this time. 332 were third reinfections, and there was one with the 4 reinfections. The definition of reinfection was anybody who had infection and then 90 days prior to November 70, they had another infection. So they have infection in November, and then 90 days before November, they had infection as well. So they're assuming that during this time, an infection does not continue so long. Although yesterday we saw the study where we saw an HIV positive person who had failed therapy. So there is a special case there, though, who had the infection for 206 days. So it is actually possible, and I'm hoping that they had taken care of that kind of scenario. Now, what do they say? What they're saying is there were multiple waves in South Africa. There was a wave by ancestral variant, then beta variant became dominant, then delta variant became dominant, and now the Omicron is becoming dominant. Then they say that during the ancestral infection, of course, nobody was infected before, so people are getting infected for the first time, so that is primary infection. Then with beta, people were getting primary infection, so getting infected for the first time, plus people were getting reinfected as well. And they said that with beta, the primary infection increased. That means more people for the first time became infected, and the reinfection risk had reduced. People who were previously infected by the ancestral variant were not getting as infected. So the protection here, so keep this in mind now that I'm going to show you the protection efficacy just like vaccine efficacy. And this credit goes to James. So I'm going to bring James's tweet over here. So James had said, don't believe the spin. The study is going to be misused to claim that natural immunity doesn't work for Omicron. What the researchers found was that prior infection provided 75% protection during the Omicron wave, down from 85% to 91% protection previously. So, what I did was I sent him a note and I said, in the study, here are the hazard ratios. Did you convert them to the efficacy numbers? And he said, yes, that is correct. I re expressed those hazard ratios in the same way that vaccine efficacy is presented. And it is a totally fair thing to do, to pick up the prior infection, previous infection, and then see, just like vaccine efficacy, what is the efficacy of the previous infection from reinfection. So, as much as these numbers, these are the numbers that authors used and then said substantially increased risk. And then these are the numbers that media use to set 3 times increased risk. So let's look at these numbers. Beta wave, reinfection risk was 0.75, or it was only 25%. So infection with the original virus reduced the reinfection risk by 75%. That is the efficacy. Similarly, here with Delta, 0.71. But with Omicron, what we are seeing is interesting. They are saying we are seeing the primary reinfection coefficient to reduce. I actually put this upwards. They saw this to be reducing. That means new infections are happening less and reinfections are occurring more, which is very interesting. Uh, South Africa is not enough vaccinated or not enough infected to be able to just say that, hey, reinfection, new infections are just not that much. But, anyways, that is the data that they have. And because of this change, that primary infection rate is less and reinfection rate is increased, they are seeing a 2.39 coefficient for the reinfection likelihood, or almost triple the reinfection. So far we are how the authors presented and what the media said. Now let's look at one more part. So their conclusion is the following. They're saying substantial ability to reinfect. And then they leave a question open, which is very interesting. Authors say that the urgent question left is for vaccine efficacy. So it's not that they're saying, hey, we don't know. They're saying, yeah, we should do the same thing for vaccine efficacy to find. But I want to do something else. I want to do what James did. This is a very important thing. And that is to look at the previous infection and the efficacy of that previous infection for reinfection. And that is this: primary infection during the wave 1 ancestral virus, Wuhan virus. And I want to show this data point as well. This is I believe page 18. So one second, please. Here. So the mean ratio of reinfection hazard to primary infection hazard decreased slightly with each subsequent wave from 0.15 in wave 1. What does that mean? In wave 1, the protection was 85%. So if we talk about efficacy the same way as we talk about vaccine efficacy, then the very first wave that occurred and people who became infected and recovered, they were protected with 85% efficacy. Now, please remember, there are all kind of cohorts over here. There are people who are aged. There are people with the compromised immune systems. There are people with the comorbidities. So we can't expect 100% protection. So 85%. Then they say 0.12 in wave 2, that is here 88% protection. Although another on page 21 they also say that the protection was 84%. Interesting for me, the authors never created these percentages and discussed them to say, hey, we went down from protection in 80s to protection to 75%. They didn't say that. This is like saying that, hey, vaccine efficacy drops from 94% to 75%. Tell me how much worried you will be. You'll say, yeah, sure, it dropped. But would you say that we are in trouble? So here, second wave, the protection was 88%. Third wave, Delta, the protection was 91%. So here, if you see, and 0.09 in wave 3. So they actually have this data. Whatever I'm presenting is from their study. Then check this out. The mean ratio of the reinfection hazard to primary infection hazard for the period from 1st November to 27th November 2021 is 0.25. What does that mean? That means protection at this time is 75%. Went from, let's take the best number, went from 91% protection to 75%. And let's take the worst number, went from 85% protection to 75% protection. Okay, I want to continue. Although it will be very interesting to actually add the vaccinated data to it. But we can't, I mean, they have already done us a favor to put all that data together for us to see and criticize and discuss, and saying that, hey, you should have done this. I'm sure that they can do that part. Now, increased transmissibility. This one part is which I want to discuss, where they said that increased transmissibility is because of immune evasion. And I think that there is more to that than just immune evasion. For example, we have, I think you've become very much aware of this chart. So this is the first infection or vaccine, and then the antibodies go up and then they wane. This is a very common mantra everywhere nowadays, that, hey, antibodies wane. When they wane, then there is a rest, immune system rest status, where when the infection or reinfection occurs, we know that during that time, people can become symptomatic. They can even end up in a hospital. And not only during that time, in some people, immune system just cannot respond well enough because of their system status. So yes, reinfection can occur, but it is not immune escape in all cases, unless we change the definition of an immune escape and we say anytime the virus would cause a reinfection, we will call it immune escape. Fine, then it is an immune escape. However, more technically, we say immune escape is usually when the immune system is trying to defend and it cannot defend because virus has done something clever to escape it. Here you can say immune escape occurred, but please remember that during this time immune system is actually not active yet. It is the memory cells that still need to become active, differentiate, proliferate, and start working. So immune system is not actively fighting, it is waking up. During that time, if the infection occurs or symptoms occur, if we want to call that immune escape as well or is evasion, then that's a matter of semantics. This is an important point. So then, here are some interesting things to keep in mind. Vaccination status for these individuals were not known. They were assumed to be all previously infected and reinfected instead of vaccinated and reinfected. Severity was not known. So tell me this, we have been having this discussion for a long time. A case that can occur in a person can happen after a vaccine or after a infection. Really, what is important is to see how severe does it become after a vaccine or the infection. If the severity is not known, in my opinion, if the severity, so this is my opinion, meaning I could be wrong, you can dismiss it and you can say, I have a different opinion, totally fine. We are sitting in a coffee shop and talking. Severity not known is an important gap. Again, hopefully they'll do another study and provide the severity as well. But if we're just talking about cases, yeah, it is more transmissible. Ideally, if it is more transmissible, it's going to be milder. And more transmissible would cause more cases. Actual variant is assumed to be Omicron. This is another thing, that from November 1st to November end, all the cases are assumed to be Omicron, and that is what is tested. So maybe it is Omicron. I do not know. We haven't sequenced. Maybe they see the sequence, but that is an assumption that this all data is Omicron. Clinical data shows better, milder outcomes. So we already know that clinical data has been showing milder outcomes. We'll see more data. But so far, if we said, for example, we are sitting here in the coffee shop and we said, you know what, this virus is really increasing its infections and it's going to really cause lots of damage. So far, the damage reports do not show that, other than more infections. But we'll see. For example, there are reports that more children under 5 years of age are becoming sick. The question is, what is the outcome? How bad it is? That will be bad if they start becoming severe and dying. If more people start becoming severe in the inpatient or ICUs or hospitals, youngsters as well, as one of the ICUs said, then we have a problem. So I'm not sitting here dismissing. I am discussing what are the unknowns here. So the reason is, based on the unknowns, I don't think that the opinion of saying go get vaccinated is the best opinion for previously infected. Although I am a pro-vaccine person. So if you ask me that should I get vaccinated, I'll say yes. So if there is an advice to say get vaccinated, yes. But putting this data in front and then saying that hey, this data is looking better than the vaccines actually. Yes, have vaccine, but previous infection data here is not satisfactory to ask for vaccination in general, boosters. So for those who have been infected, I believe that people who have been infected or have had previous vaccine, some of them need boosters based on their immune system's status. Now, protection dropped from 84 to 91% to 75%. That is a problem we are discussing. Is it sufficient? I want to give you an example of a study here. This is a study in the US, SARS-CoV-2 vaccine protection and deaths among US veterans during 2021. And in this study, I want to take, so they have done two discussions here. One is number of cases or infections, and the other one is vaccine efficacy for death. And if we're just talking about infections, here is how the data looked from Feb 2021 to September 2021. Vaccine efficacy against infection dropped from J&J, dropped from 86% to 13%. The researchers from from South Africa have shown that the Omicron's capability caused the previous infection's efficacy to drop from 84 or 91% to 75%. Pfizer, 87% to 45%. Maybe, so this is 6 months. Over there, I do not know exactly what is the distance between the the infection and then the reinfection. That would be something to look at. Then, reinfection is not immune escape in all cases. Just like breakthrough is not immune escape in all cases. Breakthrough doesn't mean that the antibodies have become bad. Breakthrough doesn't mean that the ADE has occurred. Breakthrough occurs because a person cannot respond very well. Breakthrough occurs for the same reason here. It can occur. Then the breakthrough can occur if the antibodies cannot work or the variant has become too different and so on. So there are multiple reasons for someone to become sick again than just immune escape. So now I wanted to remind us, we saw in the beginning, WHO says a different vaccine may not be needed. How is it that antibodies produced by vaccine will be better, same ancestral antibodies, while the ancestral antibodies by the ancestral infection cannot be better or cannot even be good? So if we take this study, again, authors have done a great job. They put the data together. If we take the study and take its data, then that would mean that the vaccine's structure would need to be looked at as well. Reinfections doesn't prove ADE. So I want to be very clear on this because there are folks who've already started talking about ADE. ADE is not yet, and fingers crossed, I hope it does not happen. ADE is not yet proved. So with this is the discussion. Please like, subscribe, and share. And if you would like to support this work, there are 3 descriptions in the links in the description. There is, you can buy me a coffee, or you can become a patron, or you can use PayPal. I am going to come back online in a few minutes and we'll discuss a little more about ADE and about the other possibilities of reinfection and if there is a immune escape that has occurred. So if you have any questions, please join in a few minutes and we can discuss another one more session.